percutaneous mitral valve therapies, as we mentioned here, predominantly is mitral valve, the E valve, which is the leader, where we have more than 40,000 patients procedures done successfully. And then those are the various other things which are coming up, percutaneous annuloplasties, taking the help of coronary sinus approximation around the mitral valve annulus. We also have caudal replacements, and mostly the data is now coming on to the percutaneous mitral valve implantations, which we'll briefly touch upon in the end. The mitral clip, again, as I said, is we have 11 years follow-up with this available, and it's able to treat, but some particular subsets of patients. About more than 40,000 cases are done. Only FDA-approved transcatheter device procedure, which is again come. Now we are expanding it further to functional mitral regurgitation, safe, efficacious, and durability is established. But the only thing is it may not be suitable for all types of mitral regurgitation. We have data coming from Everest showing that more than 5-year follow-up. As far as the MR regression is concerned and the patient being asymptomatic is concerned, we are equally okay like surgeons. But when it comes to repeat procedures or repeat interventions, that's where there is slightly more repeat interventions required, like with what happened in coronary, even for this mitral valve procedures. So that's about, we have long-term follow-up of 11 years with mitral clip, and then the Everest trial, that's what I mentioned, basically the event-freeness is okay, but sometimes repeat procedures are required. Now we are going on to functional mitral regurgitation area, co-opt, reshape, and many other trials are being planned. And that's how it's supposed to progress in the coming years together, where probably by end of this year we will be doing more than 50,000 procedures. And the co-opt trial is basically looking at whether this sort of device could help in heart failure patients also. The other thing which has come up by Edward's colleagues was Pascal. This device, this is supposed to have slightly more advantages than E-valve because of better cooptability. And then that is paddle spacer clasps Alfieri. That's what is the repair system. It's again, both imaging modalities are important. Fluoro, 3D TE helps in this. And it's another good, useful alternative modality. As late as August 2017, Lancet, we got some new data published with this Edward mitral valve repair system. It's again supposed to be good in controlling some sorts of MRs. Other type of modalities come percutaneous coronary annuloplasty, which is coming up, Carillon device. We go straight from jugular into the coronary sinus, and depending upon the size required, we can shape the annulus and reduce the size and improve the cooptation of mitral valve leaflets. There are various trials going on, Titan 1, 2, and then we have now shown that effectively regurgitate into volumes, orifice, and vena contracta decreases its modality. This is about, again, CMARC approved, and then total number about 600 plus procedures are done by this device. Other thing which is coming up is this direct annuloplasty with surgical like rings. I would be brief in this cardioband. Again, it's an implant success rate is quite good, and MRs regress significantly, as noted here. Mitral line, this is again procedure which is about to become part of multicenter trial, which is again basic taking knowledge of surgical colleagues how to do it. And then about 61 cases are done by this procedure. This millipede is again a surgical technique. It's not really percutaneous. I won't go on to it. There's again various types of annular reduction procedures are being tried. There are also attempts to use radiofrequency ablation to decrease annular size and so on and so forth. Caudal replacement, taking help from colleagues, neocaudal and implantation through TE as well as fluoro is also being tried. I'm surprised to see that more than 50 cases are already done with this procedure with significant reduction of mitral regurgitation happening. So this is another important thing I would like all of you to concentrate. This high life is a transcatheter mitral valve implantation system which is coming up. We always used to think whether you can use the coronary sinus as a base to implant the valve in it. That's how the bioprosthetic valves degenerated. We've started using aortic valves. This is basically aortic valve system which is started implanted, and then first-in-man studies are done. Then we have about 6 to 8 patients already implanted. The challenges are regarding LVOT obstruction and in keeping the device safe in the position, and so you need to see the long-term durability. So compassionately, this is being tried. Effectively, again, it is regressing the mitral regurgitation. These are some of the pictures, how it is done, ring insertion and closure. and then transapical delivery, the valve is done through that, and that's how the valve sits. And then 3D echocardiogram helps significantly in doing this procedure along with the outcome. That's how the CT images look after the percutaneous valve implantation done. I think then patients are supposed to be improving. This is a recent data published with a few number of patients. See the explosion which is likely to happen in this era. There are so many companies are interested to come into newer field. Edwards, as usual. Then High Life is what I mentioned. If you see this, all the important companies like Medtronic, Abbott, Edwards, everybody is coming with their own valve. So it just looks like it is more going towards transmitral valve implantation. But what I feel is, apart from the various intellectual properties, various things go on, if you see whether you put it transapically or transeptally or transatal, with each advantages and disadvantages of each of these methods. But if you see what is more important is the native mitral valve anatomy. As I always said, surgical colleagues, it is important to preserve it. So transcatheter repair is not just like one type of modality where we had it in TAVR, but it is basically amalgamatum, a toolbox which you require to give depending upon the anatomy and pathology which leads to MR. So obviously MitraClip is the leader as of now today, but various types of leaflet pathologies and adversive pathologies will dictate what we'll use. So there will be both for both types of repairs and replacement. But always, as we said, patient's own mitral valve apparatus is the best. So always we should try to preserve it, and upon it we should try to improve upon to see how best we can decrease the regurgitation. Thank you for a patient hearing.